All right, I think we should get started. It's right about 9:30, so we'll close up the doors. I'm Lana Melendes. I'm the Pulmonary Hypertension Director at the University of New Mexico, and it's my privilege to lead this session on diagnosing pulmonary hypertension and is your pulmonary hypertension diagnosed correctly. And I actually am very privileged to sit up here with some esteemed colleagues of mine. I have to my left Dr. Bull, who is at the University of Colorado, and he runs the Pulmonary Vascular Disease Center there and is a professor of medicine. Dr. Adaani, who is at Housten Methodist at Baylor and runs the lung center as well as the pulmonary hypertension program as their director, and then Charles Gallegos, who is at the University of New Mexico with me as my nurse practitioner and pretty much runs my program for me. So today, I thought a long time about how I was going to introduce this type of session and tried to come up with something very creative and realized that actually something my 8-year-old son said was enlightening to me. So I wanted to just share that story before we get started. I had my suitcase out a few days ago getting kind of ready for things, and he saw it and intuitively had said, "Mom, are you leaving?" And I said, "Yeah, actually, I'm going to be heading to a conference." And he asked me where it was and what it was. And, you know, pulmonary hypertension is not an easy thing to explain, as I'm sure all of you in this room have tried to do at some point in your life to somebody, and it's just not that easy. And so I finally just said, you know, I'm going to go and I'm going to meet with some patients and their loved ones and their friends, and, you know, they don't necessarily feel very good. And he said, "Mom, go make them feel better." And I thought, that's exactly right. Very rarely does somebody go to a physician or a provider or a doctor's office or a hospital unless they don't feel well. Nobody wants to be there. Sometimes the doctors don't want to even be there. But realistically, you went because something made you go. And I think sometimes we forget about that aspect of it. And in pulmonary hypertension, it really is the point where these symptoms need to be better defined and they need to have an appropriate diagnosis, because unlike other diseases potentially, without the right diagnosis, we may do the wrong thing and you may not feel any better and you may potentially even feel worse. So this session is really to try and talk about how all of us together come to the correct diagnosis so that at the end of the day we can try and make you feel better, and you will feel better. So in thinking about that, I thought, okay, well, the name is diagnosing. And so I looked up the definition in the Webster Dictionary, because although I use diagnosis all the time when I'm talking to patients, and it's a label that people get, in reality, I didn't know what the definition was. And so in the Webster Dictionary, it was defined as the art of identifying a disease by its signs and symptoms. And I thought, oh my gosh, that's really lovely, the art. So we talk about the art of medicine, but for me, this disease epitomizes that. It's the point where you take all those pieces of a puzzle, all of the things that your patient is telling you when they're sitting in front of you, because every person that has ever walked into my office is completely and utterly different than the person I just saw. And that we have to remember that in moving forward, so that when we get those pieces and we put that jigsaw puzzle together, that it makes a picture that makes sense for us to be able to then move forward and take care of them. So in terms of the session, kind of the layout for what we'll do today is I'm going to go ahead and sit down, because this is supposed to be about all of us, and talk about really the classification of pulmonary hypertension. And then I will turn it over to Todd, and he's going to go ahead and talk really about the definition for pulmonary hypertension and pulmonary arterial hypertension. And Charles Gallegos is going to talk about this huge workup that some of you have likely had, or friends or family have had, and why all of these tests are done. And then Dr. Frost is going to go ahead and continue with really more of the populations that we consider higher risk and how we approach those patients. So with that, I'll take a seat, and hopefully everybody can see me. This was my chance to be taller than my colleagues who dwarf me. So when it comes to the classification system, I really look at pulmonary hypertension and I think of it as a very large umbrella. I try to think of things simplistically. And it really is a term that encompasses many, many different diseases underneath it. Can you guys hear me okay? I just saw our sound guy jump down. So within that, the World Health Organization gets together about every 5 years, and they get experts from around the world in pulmonary hypertension to meet and look at all of the literature and information and try to help us better define, what we're seeing, what we now know, what we should be doing for all of these groups of patients. And under this umbrella of pulmonary hypertension, they really have defined 5 different sets of groups of people that develop pulmonary hypertension. And the first group is kind of that very special, very rare disease called pulmonary arterial hypertension, really a disease of the blood vessels, the arteries of the lungs, that becomes dysfunctional and starts to cause the changes that affect the heart and then cause the symptoms that often is when people present to a doctor or to a provider. What's interesting is within that group, when you look at the people who develop PAH, they're so different. And it's where I think things can be very confusing, because you have patients who are never really found as to why they have developed it and called idiopathic, and a very frustrating thing for the patient, for their families, and for the doctors, because we still are saying, we know you have this, we don't know why you have it. And they're learning more and more. I sat in a session yesterday about looking at, the genetics of it and, those types of things. And then there's a familial component where families tend to develop this. It's genetically based. And then it moves on to even more rare diseases like connective tissue diseases, scleroderma, lupus, rheumatoid arthritis. And then jumps to patients who might have an infection such as HIV or schistosomiasis, or patients that have been born with a hole in their heart or a reason that they had it. So all these patients coming from different walks of life who all develop potentially the same types of symptoms, and ultimately we treat very similarly. So that's our kind of group that I think, in terms of the Pulmonary Hypertension Association and some of the driving force behind it, has really tried to do better at taking care of. And then we move to group 2, and group 2 is where about 80% of people who have pulmonary hypertension really sit. And those are people who have a left heart disease or a valve problem. They're patients that if we treated the same way as we did group 1, they actually probably would do much worse. So being able to distinguish between those two groups, but both groups still have this label of pulmonary hypertension. And so it's really getting to the nitty-gritty of why. The group 3 is more because of lung diseases or low oxygen, people who have sleep disorders, where it's actually the tissue of the lungs that potentially is the driving force behind it. And that those patients, again, they need a different type of therapy that will hopefully make them feel better. And then group 4, under this umbrella of pulmonary hypertension, is again a very unique group of patients who have really kind of scarring within the blood vessels of the lungs, typically as a result of blood clots. And so this group is a group that actually potentially is curable with a type of surgery. There are also now medical therapies or medical therapy available. But you don't want to miss someone that you could cure a disease that you would need to treat differently. And so the workup that Charles will talk about really helps us to try to figure out where everybody, each individual person, fits in that. And then the last group is a group of many different diseases, most of them quite unusual, that develop this, and we're still really learning a lot more about how we best take care of that group of patients. So I know that it was just a bit of an overview, but I think it will help then as the rest of my panel kind of talks about their components. And at the end of this, our goal is that this is a discussion. We really don't want to stay focused on any one doctor or one person's individual test, but that we try and really, work together to have a session that allows us to, to talk back and forth and have the opportunity to engage each other. So with that, I'm going to turn it over to my colleague, Dr. Bull.
Great. Lana, that was thanks for that introduction, that very eloquent introduction, and the wisdom of the 8-year-old as we come through, which a lot of truth comes from that always. So, as Lana mentioned, I'm Todd Bull. I am Director of Pulmonary Vascular Program at Colorado, and have had the honor to come to this meeting for a number of years now. I find this is a fantastic meeting, and these sessions, I think, are really a great opportunity for you guys to get questions in. So I'm going to keep our comments short as we can, so we can kind of see what it is specifically you want to talk about. But what I was tasked to talk about, actually, Lana really covered very nicely, and so I'll just try to hone in on it a little bit here, which is the difference between pulmonary hypertension and pulmonary arterial hypertension. So PH versus PAH. And quite frankly, that's a distinction that honestly confuses a lot of physicians. A lot of, in a big teaching hospital, when I try to explain this to the residents, it's not intuitive for them, and it takes some understanding. So if it's confusing to you, do not feel bad. It confuses docs on a regular basis. But really what I'm going to tell you first is our hemodynamic definition of this. So a little bit of what we call doctor speak here. Then I'm going to break it down and sort of say what that really means clinically. And so the hemodynamic definition, which we have to really have a heart cath to describe for us or to tell us about, so we'll hear about that in a minute, for pulmonary arterial hypertension, PAH, is that you have to have a mean pulmonary artery pressure. So just like when the doc takes your blood pressure in the office, you have a systolic pressure, a top number, a diastolic pressure, a bottom number, and the mean of that pressure is just the average or the mean of those two numbers. We can measure that same thing in the pulmonary arteries. So by placing a catheter through the heart up into the pulmonary artery, we can measure a systolic pressure, a top number, a diastolic pressure, a bottom number, and a mean pressure. And we know what those pressures should be in the most of the population, a normal pressure, if you will. The definition of pulmonary hypertension, let me just start with that, is a mean pressure of greater than 25 millimeters of mercury. So greater than 25 millimeters of mercury defines pulmonary hypertension. Your pressure is higher than it should be. Most people without pulmonary hypertension run a mean pressure somewhere between 18, maybe 15 to 18. So 25 is above normal. That's our definition. Now, if we take that and say, what is pulmonary arterial hypertension, we put some other criteria in place. Not only does your mean pressure need to be above 25 millimeters of mercury, but the pressures on the left side of your heart need to be within a normal range. And that's something we call the wedge pressure, which we measure with the same catheter. That wedge pressure should be less than 15 millimeters of mercury. Sometimes we tweak the definition a little bit and we say 18, but as a general rule, less than 15 millimeters of mercury. Okay? And then the last part of it is we put something called the resistance in place. And I think back to physics, those of you who remember physics, it's essentially how hard it is for the blood to move through the vasculature, what is the resistance to flow through the vasculature, and that should be less than something we call 3 Wood units. That's our current definition. That's what we defined at the Nice meeting and previously at the Dana Point meeting, which is these national or these international meetings that occur every 5 years. So again, pulmonary hypertension just means your pressure is high. Pulmonary arterial hypertension means that it's high and there's some other criteria in place. The left side of your heart pressure needs to be normal. The resistance going through that vasculature needs to be elevated. Those are our hemodynamic definitions. Now, what does that mean practically? All right, that's how we define it as from a physician standpoint. That's how we make big decisions about treatment. But what is that really getting at? All right, and that's really what Lana was just telling us about. Pulmonary arterial hypertension really means that the arteries going down to the lung, right before it gets to the capillary, right before we have oxygen exchange, there's something wrong with that artery on the right side of your heart. So moving from the right side of your heart to your lung, that very small arteries before we get to the lung, there's something amiss there. And all those kind of disparate ranges of diseases, so idiopathic pulmonary hypertension, scleroderma-associated pulmonary hypertension, HIV-associated pulmonary hypertension, liver disease-associated, congenital heart disease, toxin-induced, such like the fen-phen epidemic. Why are all those diseases put into one group, that pulmonary arterial hypertension? Because they all have, right before you get to your lung, something wrong with what's called the pre-capillary pulmonary artery, the very small arteries. Some very strange proliferation of cells has happened there. It's blocked the artery. A lot of what our labs, my lab, other labs across the world are trying to figure out, why did that occur? If we could figure out why that happened, we could derive therapies to maybe make it go away. That's sort of our ultimate goal, is how are we going to fix that by figuring out that funny proliferation of cells. So that again is pulmonary arterial hypertension. Now that, even though there's kind of a long list of diseases that can cause that, it's very, very rare. All right, this is why we're all gathered here at these conferences to talk about a condition that's quite rare, okay, which a lot of healthcare providers then don't understand because it's rare, because a lot of research had previously not been put towards it because it was rare. But this organization, the PHA, really focused our attention on this, focused that this was a very important problem, even though it was a relatively rare problem, and got research stimulated so we could try to figure out better treatments. And so really all these 14 therapies that we now have are because people realized even though this was a rare problem, it was a potentially very serious problem, and we needed to focus on it. Now if we back up again and talk about pulmonary hypertension, again that just means your PA pressure is greater than 25. That is most those other four groups, okay, so left heart disease, something wrong with your lungs causing pressure elevation, some blood clots or some conditions we don't understand at all. Those are much more common to have your pressures high. And some of your in this room might have that problem, pulmonary hypertension, but not have pulmonary arterial hypertension. And so one of our big challenges now, one of all of our challenges, is how to figure out how to treat that actually much more common problem of pulmonary hypertension without pulmonary arterial hypertension, because they're very different. That's what Lana was sort of just referring to. Our treatments for pulmonary arterial hypertension may not be right for pulmonary hypertension in general. And just as an example, so if you walk around with low oxygen is a very potent pulmonary artery vasoconstrictor. Low oxygen makes your pulmonary arteries clamp down. They will make your pressures go up. Our treatment for that is to try to fix that low oxygen. If we, so we add oxygen, we try to figure out if there's something else wrong with the lung that we can correct, or their blood clots, etc. And if we can do that, a lot of times the pressures will come back to normal. So it may not be that we need a bunch of these medications. It may be that we need to raise oxygen in some way, shape, or form. And it's important for us to distinguish that. A lot of these tests is what we'll spend time doing. So with that, I will stop, because I think we can now move on to the testing portion of this. How do we figure out, is this pulmonary arterial hypertension, or is this pulmonary hypertension of some other cause?
So thanks for coming out. So I wanted to summarize some of the testing we use to help us distinguish pulmonary hypertension from pulmonary arterial hypertension. Can you all hear me? Good. So when there's any suspicion of pulmonary arterial hypertension, it usually begins with an investigation with a transthoracic echocardiogram. So this is an ultrasound of the heart. It's quick, easily obtained, non-invasive, and gives very detailed information about the heart. We can see the structure of the heart, the walls, the diameter of chambers, the estimate pressures within the heart, estimate pressures within the blood vessels within the heart, and via this way start to, if there's suspicion of pulmonary arterial hypertension, we can see changes that could clue us in that this is PAH or PAH. Some of the things that are identified with the transthoracic echocardiogram that may indicate pulmonary arterial hypertension are increases to the diameter of the chambers on the right side of the heart. Sometimes there is bowing that occurs in the walls of the heart as they bow towards the left side because of increased pressures. There's estimates of the pressures that may indicate pulmonary arterial hypertension may exist. So very good testing. As accurate as the transthoracic echocardiogram is in giving us information, it's not accurate enough to make the diagnosis of pulmonary arterial hypertension. So a very good tool to the potential presence of PAH, but not a very good diagnostic tool. I want to talk about some of the tools we use to try to differentiate pulmonary arterial hypertension from pulmonary hypertension that may be due to lung causes. Some of the testing is pulmonary function testing. So pulmonary function tests are a way of checking to see if there are diseases of the lungs or diseases of the airway. The testing measures flow of air in and out of the lungs, can measure volume within the lungs, it can measure the gas exchange that occurs from the lungs into the blood vessels, in that way giving clues to the potential for pulmonary arterial hypertension. Some of the things that we see in one of the things we see in pulmonary arterial hypertension is a problem with diffusion of gases across the thickened blood vessels in pulmonary arterial hypertension. In isolation, in other words, the other testing is seemingly normal. So very good testing, very accurate, non-invasive as well, but not accurate enough to make the diagnosis of pulmonary arterial hypertension. Some of the imaging that's used is chest x-ray. So if someone comes in and there's any suspicion of pulmonary arterial hypertension, a chest x-ray may be obtained. The chest x-ray provides imaging of the heart, the lungs, bony structures, blood vessels that may give clues to the presence of pulmonary arterial hypertension or give clues to lung diseases or other heart diseases. So non-invasive, very good testing, very accurate testing, but again, not accurate enough for pulmonary hypertension diagnosis. Lastly, VQ scan, ventilation perfusion scan, very important testing. So this is testing that's looking for the presence of clots within the lungs and the potential for chronic thromboembolic pulmonary hypertension. As Lana mentioned, very important to identify this, as it's one of the potentially curable forms of pulmonary arterial hypertension. So for us, we stress that any investigation into the presence of pulmonary arterial hypertension, it's vital that this testing gets done. The testing itself looks at blood flow and airflow within the lungs, and the imaging can tell if there is a potential for a blood clot or chronic thromboembolic pulmonary hypertension that may exist. Lastly, I wanted to finish off with right heart catheterization. So the right heart catheterization is mandatory for the diagnosis of pulmonary arterial hypertension. It is our gold standard for the diagnosis of pulmonary arterial hypertension. The hemodynamic definition that Dr. Bull talked about is obtained via this method. It is invasive testing, so it's accessed by access into a vein. During the testing, pressures can be measured, oxygen levels, pressures within the heart, pressures within the pulmonary arteries. It can indirectly measure pressures on the left side of the heart, telling us that this may be a pulmonary hypertension cause due to left-sided heart disease and not so much PAH. During the testing, it allows for, if the testing shows that the values reach certain parameters, certain specialized medications can be administered during the right heart catheterization that would tell us about a person's potential responsiveness to specialized medications. So very good testing. The testing also tells us about the strength of the heart, the severity of the pulmonary arterial hypertension, so it becomes a very important guide for us for selecting therapy and making sure that the appropriate therapy is prescribed for the pulmonary arterial hypertension. So in the hands of a skilled operator, and I work with Lana, the testing is very safe and by design more uncomfortable than painful, and vital testing that we need. So we set up like that, and since it helps us guide our therapy, we want to make sure it's a good, safe procedure for people. And knowing that we often have to repeat it, we try to make it a very comfortable procedure for people to have. That's about all I had, Lana.
All right. think that then leads us into our last sort of discussion that Adaani is going to take care of in terms of some of the kind of more high-risk groups, and then we'll open it up to all of you guys to really guide us on what you want to talk about.
Okay, so I've been given the dreariest topic to talk about. I'm going to talk about screening for high-risk individuals. So let me just say that screening usually implies that you are looking for evidence of a disease prior to the onset of clinical symptoms. And I would love to say that's realistic in pulmonary hypertension, but the reality is we don't do a very good job of screening even in symptomatic patients. So if you think that the old NIH registry told us that it took about 1.5 years from the time of onset of your symptoms to your being told that you had pulmonary hypertension, that's a very long time to have a bad disease and to be laid up, off work, going to hospitals, going to emerge rooms, and having your family wondering what the heck was the matter with you. The Reveal registry has told us that we're better at finding the diagnosis earlier, but we're not much better. In fact, it still takes about 1.1 years, so like something in the order of 13 months from when you first get symptoms till when somebody says, your heart cath shows you have pulmonary hypertension, you're going to need therapy, and you definitely do have pulmonary hypertension. So a long time before any one of those three things happen. So the concept of screening isn't really screening. What we're looking for, okay, is trying to make the earliest possible diagnosis of disease in people who are at risk for disease, and nowadays, frankly, at risk for disease and frequently symptomatic. So, in fact, nowadays still about 21% of patients have symptoms for about 2 years before they get a diagnosis of pulmonary hypertension. So are we where cystic fibrosis is yet, where you do a little blood test at birth and it tells you if you have cystic fibrosis? No. Okay. There are a couple of other things just to keep in mind when we think about screening, and this is sort of sounds like a negative thing to say, but I want you to think about this long and hard. You want to know as early as possible when you have a disease, and the main reason you want to know when you have the disease is so you know, A, there's really something the matter with me. I'm not nuts. I'm not out of shape. Okay, I have a disease, and the fact that nobody's been able to recognize it is their problem, not my problem. Okay, so you want to know it for yourself. You want to know it. The medical community would like to know as soon as possible when you have disease, because in every other disease, the earlier you find a disease, the more likely you are able to change the course of that disease. Maybe stop kidney disease in a diabetic patient, or heart disease in a diabetic patient, or find that breast cancer early so the person doesn't die of disease. What you don't want is simply to know about the disease a year earlier. Knowing about the disease without changing the outcome doesn't do much. So we don't want just more lead time. We'd like to know about earlier disease so we can learn about the earliest markers of the disease, potentially change the outcome of the disease, but very importantly, treat the patients in a way that changes their long-term outcome. So we're not just having more lead time for the disease, we're actually changing the course of the disease and letting patients live longer. So the objectives of screening for a disease are longer life, better quality of life, fewer complications of disease, and from a scientific perspective, earlier recognition of disease will allow us to see what the early markers, earlier contributors to disease onset and progression are. So clearly advancing the science is really important, but more importantly than that is, are we now at the point where if I screen for a disease and tell you, yes, you have the disease, your knowing about it earlier and my knowing about it earlier will actually make a difference to the long-term outcome of that disease. And I will tell you that, as Todd alluded to, we've had 14 new drugs that have broken upon the scene for pulmonary hypertension since 1992. We've got careful strategies to identify the disease. We know how to distinguish the different sorts of pulmonary hypertension. So for pulmonary arterial hypertension, we now have 14 medicines. But I have to tell you that until about 3 years ago, I couldn't look you in the eye, or even 2 years ago, and tell you that in people with the earliest form of the disease, our treatments clearly prolong life and make it better. We know from Reveal Registry now that people who are in fact living longer, okay, at the time of the original NIH registry, which was in the 80s and before any therapies abounded, the median time from diagnosis to death was about 2.5 years. Now Reveal tells us in the contemporary age, right now, in the year 2000 plus, median survival is about 7.5 years, so much, much better. But still, patients are largely presenting when they're what we call functional class 3. So very bad, very symptomatic disease, not screening, okay, not early disease. These are people who are short of breath, doing the activities of daily living at a reduced pace. So the critical question is, if I know about your disease earlier and I can identify it when you're really at the stage where you can do your activities of daily living and do them at a normal pace, but you're a little more puffed out or a little uncomfortable, okay, is that really knowing at that stage and being treated at that stage, is it going to make a difference? And I'm not going to go over all the studies that have been done recently, but I will say that recent studies have shown clearly that early therapy, aggressive therapy in functional class 2 patients, the people that we see in studies with the mildest disease, clearly produces benefit. People don't get hospitalized and their disease doesn't progress. So we now have additional stimulus, not just curiosity, not just reassuring people that yes, they have a disease, but actual data that says that the earlier identification of a disease does make a difference to outcome. So the next step, when I'm talking about screening now, I'm going to talk about it in 2 senses. We'd like to have earlier recognition of disease in all pulmonary hypertensive patients, but we need to get a clue to how to recognize early disease by looking at high-risk populations. So who are high-risk populations? So obviously one of the earliest risk populations and the largest risk populations are people who have heritable pulmonary arterial hypertension. So about 6 to 8% of all people with pulmonary arterial hypertension have a heritable form of the disease. They either carry a recognized genetic mutation or have a family history, other family members with pulmonary hypertension. And we know that somewhere between 20 and 27% of patients, let me correct that, of individuals in a family who carry a genetic mutation, they don't have themselves the disease on day one. They were screened because another family member has pulmonary arterial hypertension. They were found to have the same genetic mutation as their family member. Somewhere between 20 and 27% of those patients have the potential to develop pulmonary arterial hypertension. So how do we think about people with heritable disease? It's a good thing to screen, but we have to realize that if we're going to screen somebody, we have to know what to do with the information. So the person who doesn't carry the mutation will heave a big sigh of relief. The person who does carry the mutation, what do we do with them? And the current recommendation is, number one, to have full genetic support, let them understand what their abnormality is in the context of the likelihood of getting the disease, and have full genetic counseling available, but probably they should be screened with echoes on a regular basis. Let me just talk about very briefly about some of the other diseases that we do screen for and how. Scleroderma represents probably 30% of all patients who have pulmonary arterial hypertension. Connective tissue disease represents probably about 50% of associates, and scleroderma is most of those. This is a very high-risk group. Through the DETECT study, they've developed an algorithm so that we can not subject everybody to an echo and not necessarily subject everybody to a heart cath, but look at serological features, a low diffusion capacity, the presence of changes in the nail bed that tell us that you have vascular disease. And those will tell us, if positive, that we need to do an echo, and the echo, if positive, will tell us that we need to do a heart cath. There's another group of patients with liver cirrhosis, and depending upon which study you look at, anywhere from 2 to 6% of those patients will have pulmonary hypertension. We still don't quite know how to discriminate these patients. It's felt that if you're not symptomatic and if you're not being worked up for a liver transplant, there is no place for just random screening of all cirrhotic patients. However, liver transplant centers very aggressively screen for pulmonary hypertension, because pulmonary hypertension will mean that the patient is extremely high risk for a liver transplant. So these patients routinely have echoes and frequently have heart caths. Congenital heart disease, anywhere from 4 to 15% of all patients with a congenital abnormality will develop pulmonary hypertension. As many as 6% will develop pulmonary hypertension, even if their congenital abnormality was corrected. So it is recommended that all those patients be regularly followed by a congenital heart physician, and that will involve things like echoes. We, and I'm sure Todd and Lana, have got people involved with congenital heart disease, adult congenital heart docs who are screening their patients. Finally, there are some other diseases. People who've had a previous blood clot, there's data that suggests that if you have symptoms still 6 months after a blood clot, you probably should have a screening echo, because as many as 4% of those patients will develop chronic thromboembolic pulmonary hypertension. And of course, in HIV, there's no standing recommendation. About 1 in 2,500 patients will get pulmonary hypertension, which is way higher than the 1 in a million or 2 in a million that Todd and Lana alluded to before. But still, you can't run around screening everybody, so the recommendation in HIV is any symptomatic patient, so an HIV patient who's short of breath should definitely have at least an echocardiogram and go from there. And I'm going to stop there. And I didn't introduce myself. I'm Adaani Frost from Housten Methodist, and I'm the director of the Lung Center there, and I've been involved with pulmonary hypertension for about 26 years. So thank you, and we look forward to your questions.
All right, so I'm going to stand up since I can't see the few over here. At this point, it's now your guys' floor. So please, Nora has a microphone so that we can hear your questions, and feel free to direct it at any specific panelist, or if not, I'll divvy out questions. I think we have one right here and then one in the front.
Hi. I was wondering if you could address blood tests, and in one particular one, high CRPs. Is there any research or connection that you're finding in your research or in your practice?
Todd, do you want to take that?
Sure. So the question was about an elevation of a blood test called a CRP, a C-reactive protein, which is a very non-specific test. It is a test essentially telling your physician and healthcare provider about inflammation. All right, it's a marker that there is some inflammatory event occurring in the individual if their CRP is elevated. Now, that inflammation could be really anything that kicks up inflammation. If you have a bad infection, a bad pneumonia, your CRP will probably elevate. Underlying malignancies can elevate a CRP. There's all sorts of reasons. But one of the things that it might clue, probably the reason that it would be sent in when people are thinking about pulmonary hypertension, is the wonder is, could this person have a connective tissue disease, something like lupus, rheumatoid arthritis, or more likely scleroderma, because the autoimmune conditions tend to really elevate CRP. Another marker called a SED rate or an ESR is another thing that goes up. Now again, non-specific, it's nothing we would hang our hat on from a diagnostic standpoint, but it might clue us in that, oh, there's something inflammatory about this pH, and maybe we should look more carefully for the connective tissue diseases. And just as an aside, we think inflammation is probably important in almost all forms of pulmonary hypertension. That's a big area of research right now. What is the inflammatory cause of pH? Could we target inflammation as a treatment? Could we settle down the immune system in a way, not just in connective tissue diseases, but other forms? So that's an active area of research at this point right now. I don't know, Adaani, do you want to add anything to that?
I don't have anything to add to that. We do it periodically. Yeah. it's not a screening tool. It can frequently be used as an indicator, as Todd alluded to, of a worse activation of disease. So we do it periodically on our patients when we see them in clinic. If it's up, that's just, as he said, another indicator that something is worse, that something is turned on. In cardiovascular disease, CRP is sometimes equated to an active process within the heart itself. And since the heart's the downstream organ, it's the organ that's getting beaten up, if you would, by the pulmonary hypertension, that it could well be a marker for signs of inflammation within the heart as well as being related to some of the diseases that can cause pulmonary hypertension.
I'm sorry for my bad English, okay? Dr. Frost, my grandfather had scleroderma, and my oldest sister had rheumatoid arthritis. I have MS. I have 16 years with MS, and I have a cousin with MS. So we have, I think in my family we have problem with immunology problems, you know? So I had 4 years with my pulmonary arterial hypertension, idiopathic. 2 years later, my diagnosis of scleroderma, but only in the blood. I don't have any clinical things, you know. So I wondering if you have any research of that complex of mixing things.
So I hope everybody heard that, but that was a very nice summary of two things. Number one, the fact that oftentimes early in a disease, we're not very good at pigeonholing people, at telling them that their pulmonary hypertension is idiopathic versus scleroderma. We've all had patients who present and we figure out that they're idiopathic, and then 5 years down the road they develop skin changes, esophageal changes, and they clearly have scleroderma or lupus or some other disease. What this lady just alluded to is the fact that there's a whole pile of autoimmune diseases. And autoimmune diseases often occur within families. Usually if you have a scleroderma patient, it is not very hard. You go back to an aunt or a sister or a cousin, somebody else will have some other autoimmune disease, rheumatoid, lupus. MS is clearly an autoimmune disease. It's one that we tend not to think of in the same category as things like scleroderma and lupus, but there's very clearly an association. I have quite a lot of patients with MS and pulmonary hypertension without any other features of autoimmune disease. No scleroderma, no lupus, no nada. I think, if anything, what that speaks to is the fact that, number one, some individuals are genetically predisposed to develop pulmonary hypertension. We already know that. Even in a random pile of idiopathic patients, we'll find 20% of people will have a genetic mutation. We're just not very good at finding genetic mutations yet. We have not been successful, at least the rheumatologists haven't to my knowledge, in identifying genetic markers in family groups that predispose to connective tissue disease. I suspect, since the frequency of autoimmune diseases is so high, having pulmonary hypertension as a manifestation, we're going to find that there are genetic cross-links and shared genetic mutations, or perhaps the things that trigger pulmonary hypertension in somebody who has a genetic mutation. Remember, only about 27% of people who carry a gene mutation for pulmonary hypertension get pulmonary hypertension. So there's got to be otherwise another genetic trigger or something within your genetic makeup that sort of turns the key in the car that you already have. And it could well be some of these autoimmune disorders. And we're looking to people like Todd, who are doing a lot of research in the cause of pulmonary hypertension, to identify some of these genetic mutations and what we call SNPs, single nucleotide abnormalities that are part of the thumbprint of pulmonary hypertension. We have a hell of a long way to go, and this is being recorded, and I shouldn't have said that.
There's no kids in here.
We're okay.
So a long way to go. But we've made, considering where we were 20 years ago, I mean, we've made huge progress. So y'all don't give up the ghost, okay? Keep pushing PHA, but we have a long way to go. And cases like this, family clusters like this, are what help guide us.
Fantastic. I think there was another question right down here.
Excuse me. Yes, I've heard a lot of people complaining about having the catheterization done because I guess either, I don't know if it's because of it's painful or it's, I noticed that you said it wasn't necessarily painful, but it's just the discomfort. And so I've never really gotten to, which one either, because I've been, like, for several years now having a lot of issues with my lungs and different things going on, and everything finally coming to a head and being diagnosed with a number of different autoimmune diseases after so many years. Still, even with the lung issues and having the echo done over and over, the high resolution CT done over and over, and even coming to different conferences and sharing information with my doctors about the VQ scan. When I went to the sclerodermatite conference, they talked about that. And I mean, even talking about the catheterization, and they still just would not do anything. I just never go any further. Finally, I have an appointment after all this time coming up in a couple of weeks with, I think it's actually with Dr. McLaughlin. But at any rate, finally, some answers hopefully. But I guess the problem is I'm now starting to ask the same question that I'm hearing people complain about. What is it about the catheterization and it's scaring everybody? Because somebody shed some light on that for me.
So,
Actually, can we do something a little odd? Can we ask how many people in this room have had a heart cath? Heart cath. Okay.
So it looks like almost half the people in here.
One? Bunch. What's the worst thing? Is it scary or does it hurt?
Yes.
It's a nuisance.
I think Adaani did a great thing there. I think that talking to people who've had it done, and it's one of the big pushes from the Pulmonary Hypertension Association, which is making these comprehensive care centers and regional care centers where people such as Adaani, such as Todd are driving forces behind getting this, so that you are in the hands of a capable operator. And then otherwise it's kind of the time that it takes to put on gowns and get IVs, and and it's scary. I mean, you're putting your hands into sort of someone else. So I think you have a lot of people around you that might be able to hopefully calm some of your concerns when just on the other side right here who...
It's not a no-risk procedure.
No.
Okay, let's not kid ourselves,
Yeah.
okay? It's a nuisance. Things can go wrong. As Lana alluded to, in expert centers, that's really rare. But it's not impossible, okay? So I think and you made an excellent point before that many of our patients, as you just saw, have multiple heart caths, and it's terribly important that people feel comfortable having it done, so they're not there sleepless, anxious, heart palpitating the night before because they're terrified of a test, and when the whole purpose of the test is to try and help make them better.
Yeah, I think that was great, and Lana, is obviously expert on all these as well. And just so we have to make sure that it's something we can do over. So we go out of our way to make sure, especially at the big centers, that it's an experience that, while the first time it can be scary, I think I think the anxiety for it ends up being worse than the action. And there's when we're numbing something up, this is where I tell them it's a little bit like going to the dentist when we get that numbing portion. But I always say, I think this would be better than the dentist because I hate going to the dentist. And then once that's numb, you really shouldn't feel much of anything. And honestly, what most people tell me is laying on that table for the 45 minutes is kind of the worst part because but we try to put music on, at least our cath. We let you pick your song. Actually, I learned some of my. I find my Pandora challenge. Now I expand my Pandora because people put these great stations on. Like, that's a great station. I'm going to pick that up myself.
We just have a couple of minutes. Who has a question?
There's a lady at the back who's had her hand up for a while.
Excuse me. It's not a question. When I had my heart catheter, I was not afraid, but the only thing that disturbed me at the time, the physician that was doing it, she gave me two choices. She would do it in my artery here, or she would go in the groin. So I selected the artery because with the artery, I could have left the hospital earlier than going to the groin. So when I was in the operating room, and she got that pulse, but when she got ready to do it, that pulse disappeared. She couldn't do it. So she poked and poked.
So there are obviously there are different ways to get to the same place in the body. It can be through the neck, through the arm, through the groin. Personally, I go through the groin on the first heart catheterization for my patients to be able to potentially give me a little bit more information. But, I think that, again, it's in the hands of the operator in terms of what's most important. And it is a vein wherever we go through. I'll let Todd, he's been doing this even quite a bit longer than me, so if there's other things that you would like to say toward that.
In some heart caths, we do go through an artery. That's to get access to the left side of the heart. So that's different than the cath that we're doing for pulmonary hypertension, which is a right heart catheterization. So we want to stay specifically on the right side of the heart. And the right side of the heart, just if you think about this, what is the right heart's job, backing up a little bit? So once our body is done using all the oxygen in our blood, once all that oxygen has been pulled by the body, all that blood dumps back into the right side of the heart through our veins. The right side of the heart squeezes and sends that blood to the lungs. You take a breath in, oxygen enters, carbon dioxide leaves, then all that blood moves to the left side of the heart. Left side of the heart squeezes and goes out to the body. So we're very specific on the right side of the heart because that's where pulmonary hypertension, that's where we measure it, or in those pulmonary arteries. Going back to the beginning, though, one of the reasons we do this cath is we want to make sure the left heart is working okay, which we can actually figure out from the right side of the heart. We want to make sure the lungs are working okay, which we figure out from all these other tests. But this heart cath is really via the right heart, via the vein. But I do want to emphasize this. We really, really cannot add treatment until we do that test. And so I'm guaranteed Dr. McLaughlin will talk to you about it. She is an expert in this area, one of the great experts in it. But before we can safely add the medications that Dr. Frost was alluding to, that we think the earlier we can do this, we think the better, that we have to know what these numbers are. And if we're adding the medicines without that, then we run the risk of potentially making you worse instead of better. And that's kind of complicated how that comes together. We probably don't have time how we could make you worse exactly, but it is very important that we know what kind of pulmonary hypertension you have. So.
All right,
You have one more quick one.
I just wanted to ask, we have a few groups of pulmonologists that have decided to do an annual cardiac cath. Is that becoming a standard now, or is this just kind of unique to them?
Go ahead.
Shall I do? You want to take it?
Okay, I think I got punted that one. There is no mandate to do annual heart caths. We have many patients who we do more than one heart cath in any given year. I have people who've had 2 and 3 in 1 year because they're sick, because we have to adjust treatment, because we're getting different bits of information from the echo, from the patient, and from the exam. There is no recommendation from the Pulmonary Hypertension Association or from the international congresses that mandates an annual heart cath. Some doctors do that because they find it gives them the most exact, specific measurement to assess how their patients are doing. Some docs like me are happy talking to the patient, examining them, looking at their walk test, doing the echo, and only doing the heart cath if, in fact, there's a problem.
So, yeah, why don't we, so do you do annual heart caths?
The only group that I think there's a little bit more guidance on are patients who are idiopathic and responsive to some of specific therapies. They tend to say they may need to be evaluated more frequently, but for the most part, no, I don't. I do it based on my patient's symptoms, and if I have other specific concerns from the objective data and testing that we've gotten.
Yeah, no, I'm the same. And I think, it's hard. I think it breaks down by centers. Some others think that they should. But to me, it's anytime we do an invasive procedure, there are risks. Again, we think we can do it safely. We've done, thousands of these between the combined of us up here, probably, I don't want to say how many, lots of that. We've done lots of them. And I think there's an incredibly important test, but you want to use it judiciously, and so I think frequently. So when I do it, after the initial ones, I do it when I can't quite figure out what to do next. Okay, so I've talked to someone, I've examined them, I looked at the echo. Do I need more treatment? Do I need less? Are we moving towards transplant? That's when I use it in that scenario and repeat scenario. So.
I think there was one more here, and then we're happy to discuss afterward as well.
This is the first time I've heard a tie-in with MS. I've had MS for 30 years, and 8 weeks ago I'm diagnosed with pulmonary hypertension. And the other question that's always been nagging at me, I have 2 grandchildren that both had tetralogy of Fallot. Now, is there any connection with this?
Well, you have said that the tetralogy, so we know that underlying congenital heart defects, so tetralogy being one of them, tetralogy meaning there's 4 different defects in the heart, and one of those is what's called a shunt, an intracardiac shunt, something called a VSD, a ventricular septal defect. We know that shunts or congenital heart disease definitely increase the risk of pulmonary hypertension. It's one of those pulmonary arterial hypertension, PAH. It's one of those causes, shunt-induced pulmonary hypertension. So that's very well recognized. Now I have to say I'm interested in this myasthenia. That's not something. So Dr. Frost apparently has just mentioned that she's seen this before. Again, one of my big areas of research is trying to tie together these various things. So I'm actually, I make a little note to myself to go back and kind of look through my patient population, because we have genetic samples on a variety of people. That I'll let Dr. Frost tell you her experience with MS and PH. So.
Well, there's a couple of aspects, just briefly, covering congenitals and familial clusters. Not all patients with congenital heart disease get pulmonary hypertension. A lot of them do. Even people who have relatively mild congenital heart disease that is surgically corrected go on to develop pulmonary hypertension. So there's clearly a genetic predisposition for the hole in the heart and for the subsequent development of pulmonary hypertension. Otherwise, all patients with holes in their hearts would have pulmonary hypertension, and that ain't the way that it is. So there's clearly, yet again, something that I can blame Dr. Bull for, which is a genetic predisposition for patients with congenital heart disease to get pulmonary hypertension. We know that autoimmune diseases that we've just talked about are associated with pulmonary hypertension. MS is kind of a bit different because there are 2 potential risk factors within MS. One is the autoimmune disease itself, and the other is that historically MS has frequently been treated with interferon, which is increasingly recognized as a possible or probable risk factor for pulmonary hypertension. So people who get interferon for malignancy, people who get it for the treatment of hepatitis, people who get it for the treatment of MS, appear to occur the incidence of PH appears to occur with greater frequency in them than it does the random population. So, and that's fairly novel information. It hasn't been fully fleshed out. So to answer your question, you've clearly got some sort of familial predisposition, which may or may not come from your gene pool, okay, for congenital heart disease in your grandchildren, okay, could come from your husband's side, your son-in-law's side, whatever, okay. But there's also the autoimmune factor that may have some repercussions. So what to do about that? I think it would behoove families where there is potential risk to, at the earliest signs of any sort of unusual symptoms, to consider screening and make sure your pediatric doctor is aware that there are risks on either side of the family that may potentially contribute to the development of pulmonary hypertension.
I have a question about that. Would the screening be an echocardiogram?
That is the recommended first screening, yes. You wouldn't screen with a heart cath. You do an echo. And we don't have any little blood tests or something that we could do for congenital heart disease as a risk, or even for autoimmune disease as a risk, quite different from what we have for scleroderma, where if we have a scleroderma patient, we can look at nail fold capillaries, specific blood tests for anticentromere antibody diffusion capacity, and only proceed to the echo then if those were positive. So we lack a lot of early screening tools for these folks, but heart cath is it.
So
echo is it.
unfortunately, our time has come to an end. I've gotten the, you got to leave. So I just want to thank all of you for being here. We appreciate what you tell us, and even today, things that will allow us to go back and maybe go from there further to learn more about this disease. So thank you, and enjoy the rest of the conference.
Thank you.